Afiq, can we start?
Yeah, we can start now.
Okay. So hello and welcome everyone to our third webinar session of the month. Today's topic will be pain and symptoms control in palliative care. So we are very grateful to have with us here today our chairperson, who is Dr. Cindy Teo, who is a palliative care consultant in Hospital Selayang. So without further ado, over to you, Dr. Cindy.
Thank you, Dr. Nisha. I would like to start by saying thank you to the College of Physicians for giving the Palliative Medicine Fraternity this webinar platform for the month of December. My name is Cindy and I'm a palliative medicine physician based in Hospital Selayang. It is my pleasure and honor to introduce my friend and colleague, Dr. Fazlina Ahmad, who will be speaking on the topic of pain and symptom management today. Dr. Fazlina is a palliative medicine physician based in Hospital Sultana Bahia, Alostar. As a clinician, she wears many hats, covering general medicine, palliative medicine, and also works closely with her community counterparts, Persatuan Hospice Kedah. So effectively, Dr. Fazlina practices both hospital medicine as well as community medicine. Today, Dr. Fazlina has the unenviable task of outlining pain and symptom management, a mammoth topic in just 30 to 40 minutes. Now, managing symptoms, especially pain, is a core competency in palliative medicine. You will hear buzzwords such as patient-centered care, holistic approach, individualized care, which basically means that you may not necessarily be getting a neat algorithm to help you practice symptom management. So I'm glad to now hand over the time to Dr. Fazlina, who will try to condense the art and science of pain and symptom management in the next half an hour or so. Over to you, Dr. Fazlina.
Thank you. Thank you, Cindy, for that kind introduction. And thank you to the organizing committee for inviting me to speak today. So it gives me a great pleasure to be here to share with you some of the points that we can actually learn from managing pain and symptoms. So I'll share my slides now. So I agree with Cindy, it's an envious task because it's actually a very big topic. But for the benefit of time, so I would focus on pain and also nausea and vomiting. So I know there are major symptoms, that is a breathlessness and also a fatigue. But breathlessness has been, I think, thoroughly and comprehensively addressed in the first webinar of this month. So therefore, I would skip and focus only on pain and also nausea and vomiting. So just to share with everybody, so when we talk about palliative medicine or palliative care, so it is synonymous with patients with cancer. So however, just to show you the projection of palliative care needs in Malaysia from 2015 to 2030, actually the number for the next 8 years or so is going to exponentially increase. And this is because the needs for palliative care is not just in cancer patients. 70% of the bulk of palliative care needs is actually in non-communicable diseases or NCDs. And that would be your chronic illnesses, your end-stage organ failures such as kidney, end-stage heart failure, COPD, Gold D, and also your neurodegenerative disease. So if you can see the projection, in 2030, 240,000 patients will be needing palliative care. And that means it is important for us, all the clinicians, to have a basic approach in managing symptoms such as pain and other major symptoms in patients with life-threatening illnesses or serious illness. So this is actually quoted from BMJ Supportive and Palliative Care, and I'm happy to say that Dr. Cindy is actually one of the co-authors of this paper. So if you attended last week's prognostication talk by Dr. Richard, I'm sure you have seen this graph. So this is a disease trajectory graph from Scott Murray, which is published in 2008. It's a long time ago, but it's still very relevant here. And I think it's going to continue to be relevant. So if you can see, this axis depicts the functional status of the patient. High, meaning they are able to do things, walk around, communicate and do things that they love. And as the disease progresses, if you see the blue line, so even though they have stage 4 cancer, initially they are well, but subsequently the disease will get the best out of them. And as they deteriorate, they will have a lot of disability, debility from physical symptoms such as pain, nausea and vomiting, breathlessness, fatigue, and others. And it also will impact their psychological, spiritual, and also social issues generally. So same with other illness with multimorbidity, organ failure, such take, for example, COPD, they have numerous exacerbations, either infective or non-infective. They recover to a certain level, but generally with time, they are going to deteriorate and will have more and more symptoms. And not to forget mentioning physical and cognitive frailty, that is really challenging to manage. So managing physical symptoms is one of the important aspects, but it is also important to pay attention to the psychological impacts such as anxiety and also depression, and also spiritual and social issues. Because essentially, if we are only using medication, we are only targeting 1/4 of the issues. So in order for you to provide the holistic management, so you need to be able to support psychologically, spiritually, and also socially. So key things in symptoms assessment in seriously ill patient, they are getting more and more common as the disease progresses. I'll show you what will be the prevalence generally. And you have to remember that these patients, when they have life-limiting illnesses or serious illnesses, they are always fatigued and also distressed. So sometimes trying to talk to them or get a long history is not possible. So in my practice, it is actually useful to use tool if possible. For example, in clinic, we use ESAs so that we screen through all the symptoms that the patient may have and we won't miss out on any. And remember, again, psychosocial and also spiritual suffering of the families and also the patient needs to be addressed. And whatever the guideline says or whatever the evidence says, it needs to be tailored. It needs to be patient-centered and also personalized. And it needs to be in accordance to patient's goal. And also good communication skills is very important. So this is, I would say, recent systematic review on the prevalence of palliative care problems in cancer versus non-cancer for serious illnesses. And if you can see, although we have a lot of numbers under cancer, but patients with COPD, chronic heart failure, end-stage renal disease, dementia, MND, just to quote some of the illness that is mentioned in the paper, actually have a significant palliative care problem or also symptom profile. For example, people always focuses on cancer, isn't it? So cancer receives a lot of attention, receive a lot of community support, but people or person living with other serious illnesses also are as suffering. But the support that they would have is probably less than what cancer patients would receive. And just to show you, in terms of pain, so up to 94% of cancer patients have pain, but the number is not actually small in COPD, heart failure, and stage renal disease. It's up to 83%. And nausea and vomiting also is quite prominent. If you see the number in heart failure is 48%, and stage renal disease is 52%. And dyspnea, knowing it's a cardiopulmonary disease, of course, COPD tops the chart with 98%, 88%, and of course, MND with restrictive lung disease. Just to mention again, because of the extensive topic on pain and symptom management, for today, I would just address pain and nausea and vomiting. And in terms of evidence, what is available out there, dyspnea has been extensively addressed, I think the first webinar of the month. And perhaps we can discuss later on if there's any questions. So we start off with pain. So for the purpose of this presentation, I'm going to focus on cancer-related pain. And the evidence stated would be cancer pain unless stated otherwise. So in a patient with cancer, if you can see the spectrum, it's actually from the diagnosis of acute cancer pain, probably post-operative pain from the surgical intervention. And after that, even if the patient has cured from the cancer, they still have pain. And we all familiar with advanced cancer and also people living with cancer. And if you could see a recent systematic review of more than 64,000 patients, despite the development of assessment tool, WHO analgesic ladder to guide choosing the right medication, continuous medical education. So in all cancer stages, 50.7% would have pain. So that means that if you go to the clinic and see your patients, and if there's 10 cancer patients, 5 of them would have pain. And it is well known that in advanced metastatic or terminal disease, the incidence will be higher, so 66.4%. And again, I mentioned, even if your patient is already cured from cancer, 39.3% still have lingering pain, and it's a constant reminder that they have a serious disease. So I would like to point out your attention to a recent study in a local PCU in QE, Queen Elizabeth Hospital in Sabah. So upon admission, 82.1% have pain, even in PCU, and it's moderate to severe. So this means that we have to really work hard on managing pain for our patients. So what are the barriers in pain management? So this systematic review from McLuth et al. In 2020 highlighted 2 important factors that contributes to the barrier in good pain management. The first one is healthcare professionals and also patient-related. Under assessment and under treatment of pain has been highlighted as one of the major barriers in achieving good pain control. And this is partly due to limitation in knowledge. There's some poor awareness of pain effect, and also the functional ability that will be affected by uncontrolled pain. Lack of insight into the pain dynamic needs. For example, if you have a patient with cancer pain, you give medication, you prescribe morphine, the pain is better controlled, but the pain control can change. For example, as the disease progresses, there's actually a study showing that as the tumor getting bigger, the requirement for increment of morphine dose also is higher. So as the tumor grows, it is important for us to review, increase the dose and manage the pain, because the patient's body is dynamic, the disease is dynamic. The other thing that is pointed out is negative attitudes among the healthcare professional. A lot of people, despite education, still have a lot of concern on the use of opioids, particularly morphine, and all the negative connotation, addiction, tolerance, and so on. For patient-related factors, education is again pointed out as the sole, one of the most important thing in under treatment of pain. So low understanding, reluctant to report pain because they are worried about opioid, and again, all these negative attitudes and influence from carers and family. So it is important for us to educate our patients, because then there are a number of studies that have shown that if your patient is involved with the care, involved with the decision making, and are educated on how to use pain medication, take breakthrough, they resulted in better pain control. So the principles in pain management, again, first one falls upon comprehensive assessment. So I cannot stress how important comprehensive pain assessment is, because by assessing the pain fully, diagnosing accurately, so we would have a good, solid foundation for managing the pain. It is important to understand the concept of total pain. And this is a concept that is brought about Dean Cicely Saunders in 1964. And again, I think I mentioned pain is not just a physical symptoms. It has a psychological impact, spiritual issues, and social impact. So if we just give medication, we are only taking care 1/4 of the problem. So altering psychological, spiritual, and social issues, altering the perception will alter the overall experience and also pain expression. So pain is not, again, just physical, it is expressed and influenced by other dimensions as well. So it is important to accurately diagnose the pain. I'll discuss in a short while and what are the types of pain and what would be the most recommended medication for the type of pain. Early introduction of anti-neuropathics. Studies have shown that increasing severity of neuropathic pain in cancer patients is one of the predictor of poor pain management. And also, again, I've mentioned participation of patients and their loved one. Patients with self-management strategies are more likely to get on top of pain compared to patients who are not educated on how to take their medicine and understand the disease. And of course, not to forget multidisciplinary team management. So just to briefly go through what would be the what we call appropriate bedside assessment on the physical side of pain, you could use the mnemonic PAIN by asking P, where is the place or site of the pain? What would be the aggravating factors? Intensity, how bad is the pain? So use pain scale whenever possible, because I think a lot of literature shows that patient-reported 2 scale is actually produces better improve in terms of pain management, because it opens an opportunity for the patient to discuss with the clinician on their pain, their concern, worries, and also objectively we can quantify the analgesic regime and also if we need to change. So the most easiest bedside, I would say, use your hands. So you can ask the patient if 0 is no pain, 10 is the most pain imaginable, what would be your pain now? So use the score, document it, and review it and see if you need to adjust your medication dose or add on adjuvants. And stands for nature and neutralizing factors. What does it feel like? What makes it better? So just to point out, when a cancer patient reported pain, so of course, most of the time we think it's disease related, but we have to remember it could be treatment related. For example, post-radiotherapy could be because of the medication that you're taking, the TKI that you're taking, and it could also be because of debility. Your patients who are bedbound with sores or pressure sores could have pain solely at the pressure sore. So diagnose where's the pain coming from and see if you could use local intervention to help improve the overall pain perception. And of course, it could be other unrelated illnesses, such as maybe osteoarthritis, maybe peripheral diabetic neuropathy, and so on. So another thing that is important is medication history. Find out whether your patient is already on opioid. So remember, tramadol is an opioid. So if your patient is on tramadol, so you know if you want to move to step 3, so you need to increase the dose a little bit because your patient is not naive anymore. And find out whether your patient cope with the pain by using substance. For example, using either like amphetamines or other drugs out there, because using substance as a coping mechanism for pain is actually associated with poorer prognosis in terms of pain control. So this is something to keep in mind. Comorbidities like liver and renal, and also don't forget to assess the impact of pain on daily activities, psychosocial, and also spiritual aspect. And just remember that many palliative care patients have more than one pain. So if possible, to try to identify each and every one, what would be the likely cause of pain. So just to go through pain types and also characteristic, I think it's important for us to understand a little bit of the features. So the pain can be divided into nociceptive and also neuropathic. So in nociceptive, you have somatic and also visceral. Somatic pain comes from bone, skin, wound, and is usually well localized. So the quality is usually stabbing, throbbing, sharp, aching. So sometimes the patient described to you as bone metastasis worsened with movement. So one of the treatment approach is NSAIDs and COX-2, but we all know in a chronic cancer patient, prolonged use of NSAIDs and COX-2 actually is associated with a number of complications. So eventually we would sort to opioid, but you can actually give short bursts of NSAIDs and COX-2. For visceral nociceptive pain, it comes from the internal organs. So that would be your bowel obstruction, liver metastasis, urinary retention, and the quality is usually squeezing quality and is poorly localized. So these types of pain respond very well to opioid. For neuropathic pain, either it's possible, probable, or definitive based on the new definition. It's associated with nerve injury. So you could get it from spinal cord compression, radiculopathy. So one of the examples is post-mastectomy or thoracotomy pain. So the quality or the way your patient described is usually very, very what we call distinct. So they will describe burning, tingling, electric shooting, and it can be associated with allodynia and also hyperalgesia. Allodynia is non-painful stimulus causing pain. Hyperalgesia is painful stimulus causing aggravated pain perception. And it can have radiation along the nerve distribution. And I think we all know that neuropathic pain is quite challenging to manage, even though opioid is still listed as the first line in managing neuropathic pain. So most of the time, neuropathic pain would need adjuvants. So now I move on to the WHO analgesic ladder. I'm sure all of you would have seen this and are very familiar with this. So this is used as a guidance, but it does not replace individualized management based on careful assessment, just to remind. So the principles would be by the mouth. So let's say if you want to choose a medication apart from guidance from the ladder. So remember, if your patient is still able to swallow medication, use oral medication. Don't straight away use a subcutaneous or fentanyl patch. By the clock, patient with persistent continuous pain needs 4-hourly medication or regular interval dosing medication rather than just a PRN basis. For the individual and with attention to details, describing the importance of educating the patient, getting the patient involved again with pain management, and also trying to adjust the medication regime to suit patient's lifestyle, waking and sleeping time. So this will increase compliance of the patient. So if you can look here, so it is divided into step 1, step 2, step 3. So if the pain is mild, you can actually use non-opioid plus and minus adjuvant. So adjuvant is a medication that is marketed not for pain, so marketed for other indication, but can be used for cancer pain and also for pain management. So let's say if the pain persists to moderate, so you can actually use opioid for mild to moderate pain plus non-opioid plus adjuvant. And in severe cancer pain, you can use opioid for moderate to severe pain, plus and minus non-opioid and adjuvant. It is interesting that internationally also we are moving away from the term weak opioid and also strong opioid. And I think probably this is a debate that we need to undertake later rather than now. So this is just to just discuss generally or briefly what is available out there in our setting. So for step 1, non-opioids, you have your paracetamol, ibuprofen, diclofenac sodium, celecoxib, and also atorvastatin. So this works well for somatic pain, remember? But because of the side effects, GI bleeding, platelet dysfunction, and also renal failure, so the prolonged use is not recommended. So if you want to use it for bony metastasis, for example, you use it for 2 weeks and then stop. Of course, opioid need to be started as well. And then if you feel there's a need to use, you can repeat it again. So remember, COX-2 selective inhibitors may increase the risk of cardiovascular thrombotic event. So just be careful on that. So step 2, opioid for moderate pain. So you have in the market tramadol and dihydrocodeine. So tramadol, you can start with a dose of 50 milligram TDS QID. So the maximum will be 400, dihydrocodeine 30 to 60 milligram with maximum of 240. But just remember, it is classified as weak opioid or opioid for moderate pain because it has a ceiling effect. So when, let's say, it exceeds the recommended maximum dose, so you have to move over to step 3. So the side effect is generally the opioid side effects, which I will discuss after this. So for strong opioid, we have available morphine, oxycodone, and fentanyl in the form of patch and also IV formulation. Buprenorphine is another opioid, but I think the classification is under atypical opioid, but it's certainly can be used also. Morphine remains the gold standard in many guidelines and also in many recommendations because it's cheap, it's readily available, and it's easy to use. So the starting dose for your opioid naive patient would be orally 5 milligram for hourly and 5 milligram PRN. So the PRN dose will be same with the regular dose. And if you are managing elderly and frail patients with liver and renal impairment, so the dose needs to be reduced and also spaced out. So this is because of, it needs to be used cautiously because of the active metabolites from the morphine itself. So if IV or subcut, you can halve the dose, 2 to 3 milligram for hourly and PRN. So if you have oxycodone available as an alternative or for a rotation, so you can start off with 5 milligram, 4 to 6 hourly and also PRN. So just remember, transdermal patch is actually to be used in a patient who have stable opioid requirement. So they shouldn't be used for patient with patient who are opioid naive, meaning that the patient has not been exposed to opioid and then use patch it. The reason being is because it takes a while for it to reach the steady state in the patient's body, the 12 hours. So in the meantime, if the patient have pain, so nothing will actually control the pain until the fentanyl kickstart. The other thing is 12 microgram per hour is actually equivalent to 30 milligram of oral morphine per day. So many people are not aware of it. 25 microgram per hour is actually equivalent to 60 milligram of morphine per day. So that is actually a considerable dose considering in an elderly or frail patient. So that's why we have to be careful on that. It is recommended in patients with impaired renal function, especially with the creatinine clearance less than 30 mL per minute. So there is no maximum dose for strong opioid. So meaning that you can push the dose further if your patient needs it. But just to discuss, so in I think one of the studies that I read, the general requirement, the general opioid requirement in a cancer patient in a general setting would fall around 200 milligram per day, and that would be 30 milligram for hourly if I can divide it correctly. So let's say if you see a patient who needs to, whom pain is not controlled and there is a need to increase the dose further and further, I think it will be best to get an advice from palliative care or a pain specialist in your hospital to help you to manage the pain. So another thing is if your patient has already been receiving strong opioids, so if the pain is not controlled, you need to increase 30% from the background. And in a patient who already on dose and stable, so consider changing it to long-acting formulations such as SR. So by all means, this is, and I'm not touching on the titration and also the breakthrough dose. So it's just a brief overview of what's available out there. So when we prescribe opioid, we should remember the side effects that is quite common and needs to be managed. Constipation is very, very common. If you prescribe a medication, if you prescribe an opioid and then your patient is not constipated, patient probably is not taking it. So prescribe concurrent laxative because opioid bind to the mu receptor, opioid receptor in the gut, it causes slowness of the gut. So stimulant is preferable. So if your patient cannot tolerate your stimulant, that is bisacodyl, so you can use lactulose. Nausea and vomiting is quite common, but it is self-limiting. So you can treat the nausea and vomiting with metoclopramide 10 milligram TDS. The drowsiness usually also is self-limiting, usually reduces within a week, but warn the patient about these side effects, not to drive and also not to operate heavy machines. For confusion and delirium, if it persists, rule out other causes such as infection, hypercalcemia, sepsis, You can reduce the opioid, but it's good if you have other opioid available. Rotation might be indicated, and low-dose haloperidol, you might need to use it. I'm going to discuss on the common adjuvants for neuropathic pain in general settings, but just to keep in mind that all this data is actually extrapolated from a non-cancer situation. Actually, in a neuropathic associated with cancer pain, the evidence is low, but given the heterogeneity of the patient's population and the observable benefit in the clinical setting, I think it is something that you cannot dismiss, and I think this is something that we need to use in order to improve, especially neuropathic pain in cancer. So in terms of antidepressants, widely available amitriptyline is still one of the best, but the number needed to harm also is high. So rarely patient tolerated this dose. You can start at 10 milligram and increase after 5 to 7 days. So the side effect mainly will be anticholinergic side effects. For anticonvulsants, gabapentin, you can start at 100 or 300 on night. After 2 days, you can increase it to BD and then increase it to TDS after another 2 days. Maximum will be 3,600 milligram per day. And for pregabalin, 75 milligram BD, and the maximum will be 300 milligram BD. So the side effect for gabapentin and pregabalin is similar. And this is meta-analysis and systematic review of a non-cancer neuropathic pain. But I think a recent systematic review for pregabalin in 2019 also, the evidence is similar. So just to point out a few things. In a patient with moderate intensity cancer pain, so the one with moderate pain score 5 to 6, actually, if you want to jump straight away to step 3, low dose morphine had, in fact, better analgesic effect compared to weak opioid with similar tolerability. So I can share with you in my practice, I usually jump the ladder. So I rarely use tramadol because I think clinical practice wise and also evidence also have shown, even if you use tramadol or dihydrocodeine for your cancer pain, up to a month, so the pain will escalate and you have to move to step 3 anyway. So in my setting where there's a lot of confusion, there's so many medications, and it's not easy to educate the patient sometimes because of social issues, and I find it easier to start low dose morphine and then advise them one go. But I'm not to say that you can't use tramadol and also dihydrocodeine. It is certainly very useful in a setting where morphine is not available or it takes time for you to get it. So you can still use it, but keep that in mind. Sometimes what we worried of, because of this 3 ladder, step 1, step 2, step 3, a lot of people think that they have to jump to step 2 first before going to step 3. Actually, you can jump to step 3 if you are managing a progressive cancer patient and you know that the disease is going to get worse anytime soon. In a patient with moderate severe cancer pain on strong opioid, regular paracetamol is unlikely to gain additional benefit. So a lot of our patients complain tablet burdens. So you can actually stop paracetamol unless your patient wants to take it, but there's no additional benefit. And always remember, consider other adjuvants for specific conditions, such as steroids for tumoral edema and neuropathic pain, biphosphonates for painful bony metastasis, and also radiotherapy. And again, if you come across complex psychosocial needs, influencing total pain from the patient or need interventional pain procedures, do seek advice. I would proceed to nausea and vomiting. I hope it's just a few more slides. I know I'm way overboard of time, but I think it's important just to highlight a few things. So for nausea and vomiting is still quite common in 30 to 40% of patients in the last year of life. And it is often multifactorial. So the commonest cause of nausea and vomiting is still impaired gastric emptying. And it could be because of drugs, autonomic dysfunction, chemical causes accounts for 1/3, and it's from drugs, toxins, from infection, gut ischemia, and metabolic, which is commonly seen, that is renal failure and also hypercalcemia. Visceral and serosal pathology, about 31%. That comes from your stretched liver capsule, obstruction of hollow viscous, and then the rest would be cortical and also craniocausal and vestibular. So just to point out, the cortical causes of nausea and vomiting, your anxiety, pain can actually contribute to the symptoms. So this is the key hematogenic pathway of how nausea and vomiting works inside the body. So we have two centers, chemotherapy chemoreceptor trigger zone, and also vomiting center. Vomiting center coordinates all these mechanical pathway that produces retching vomiting. So CTZ is in the area of fourth ventricle, floor of fourth ventricle. It is outside the blood-brain barrier, and it receives input or stimulus from the toxins from the blood, from the motion labyrinth, and also higher centers such as emotion. Vomiting center receives input from higher centers such as emotion, anxiety. That is where your anticipatory vomiting comes from. The moment the patient sees the chemo, they started to vomit because of past experiences. It also receives input from CTZ and also from the gut. So the main receptor in CTZ is dopamine, 5-HT3 and NK1, and here is muscarinic and NK receptors. So why do I show this figure? Because so traditionally in the palliative care, so targeting the receptors that probably responsible for nausea and vomiting would likely improve the symptoms. So I'll discuss about this afterwards. So again, history and assessment is the mainstay in terms of reducing what we call the proper management. So from the history and clinical features itself, it gives you an idea what's going on inside the patient's body. So if the patient has abdominal pain and vomiting, so most likely the patient has bowel obstruction or organic etiology. So if your patient have large liver and ascites, so the stimulus is actually from the gut, from compression of the bowel, also feeling fullness. Drug-induced would have persistent vomiting. A patient who have chemotherapy and radiotherapy would give you the history. This one is the one that I discussed just now, anticipatory nausea and vomiting when they are anxious from previous past experiences from receiving chemotherapy. Confusion may indicate metabolic abnormalities, and intracranial disease usually is associated with other neurological deficits. So in palliative care, traditionally, so we would go towards the mechanistic approach and empirical approach. Mechanistic approach is when you identify what will be the likely cause of the nausea and vomiting, then you identify the trigger, the receptor, and then use the drugs that blocks the receptor. So that will be your best antiemetics. But empirically, especially in end of life, where probably finding or reversing the causes might not be that significant. So empirically, you can use a few medication. But remember, regardless, treat simple reversible causes such as constipation, hypercalcemia. You could easily correct it in a hospital setting with biphosphonate, and also ICP by the use of steroids to reduce the edema. So this is the first line antiemetics based on mechanistic approach. This is based on PCF7, Palliative Care Formulary 7. But I'd like to mention a recent systematic review that is just out by Davis M. et al. So if you use the mechanistic approach by identifying what will be the likely cause and what will be the likely drug that blocks the receptor. So if it's gastric stasis and functional obstruction, so you would use prokinetic, and that would be your good old metoclopramide. So the route, you can use either oral or subcut at 10 milligram TDS, or you can use infusion. Metoclopramide can be used as a subcutaneously, so in case you're not familiar. Because a lot of times, sometimes it's not easy to get IV line in our patients. So for chemical causes, so remember the CTZ area, so the main receptor is dopamine. So dopamine antagonists such as haloperidol. Metoclopramide also has a little bit of dopamine antagonist activity. So you can start for halo 0.5 to 1 milligram on night PRN, or per oral 0.75 to 1.5 on night PRN, or infusion. So for raised ICP, so you can use promethazine. Cyclizine, which is recommended in many guidelines, is not available in Malaysia. Just to point out just now, so the recent systematic review using empirical approach from Davis et al., metoclopramide and also haloperidol is recommended as a first line regardless of the etiology. But just be mindful that metoclopramide is contraindicated in bowel obstruction. So for step 2, let's say if metoclopramide, haloperidol is not working, so I'd like to point out olanzapine because I mean clinically also I find it's very effective and the evidence also is quite robust. So it is mentioned as a second line in the systematic review, and a recent randomized controlled trials, placebo control from Navari RM et al. The use of olanzapine actually reduces the nausea scoring by 8 points, meaning that if they score 10 out of 10 nausea after olanzapine, it's only 2 out of 10. So it's very effective. I think in my practice also, I find it very effective. It's just that cost is an issue and also drug availability. So just to share with you, let's say if you have intractable vomiting, there are other medications available to treat the patient. So just to recap, actually from this systematic review, again, metoclopramide is a reasonable initial choice for palliative care patients with nausea or vomiting whom a cause is not identified. Because actually, even though there are lists of causes, sometimes we just couldn't find where is the source. And for end of life, empirical treatment with haloperidol and metoclopramide is appropriate. And then also, actually, either you use mechanistic or etiology-based approach, it's actually no better than single empirically chosen antiemetics such as haloperidol and metoclopramide. Just keep in mind, if your patient have brain metastasis, you could consider dexamethasone. For patients with malignant ascites, sometimes we tend to wait until the ascites is really full-blown or it's really tense, then only we improve. But actually, if the patient has quite a considerable amount and have nausea, it's good to actually do a symptomatic release, because I mean, this study has shown that it reduces the nausea score by 2 points or more. It actually improved the patient's quality of life and ability to eat and all that. So I didn't discuss 5-HT3 because it is indicated for chemotherapy-induced nausea vomiting, and it's actually out of the scope of this topic, and it's not indicated for the first-line treatment for causes other than CINV. So just remember the practical tips: positioning, calm, relaxing environment, clean tasting food, complementary integrative medicine measures that I will not discuss further. So in summary, I think we need to be aware that palliative care patients have high burden of symptoms as the disease progresses. And, you know, as you could see just now, palliative care needs in our patients, especially in Asia, is increasing. So it's important to have awareness on this patient, or recognizing that this patient have palliative care needs, and also have some basic skills in managing some of their symptoms. And it is good, you know, because we know that all these patients will eventually be in general wards and not specifically in palliative care treatment. So with that, Cindy, I end my presentation. Thank you very much.
Thank you, Fazlina. To all the participants, I'd like to encourage you to write in your questions in the Q&A box. We have a few questions. The first one here now, Fazlina, is, I think, with regards to neuropathic pain, pregabalin versus gabapentin, which to pick?
Okay, thanks for the question. Again, remember, because the evidence is extrapolated from non-cancer patient. Actually, the indication, especially for pregabalin, is post-herpetic neuralgia and also I think peripheral diabetic neuropathy. So in cancer patient, actually, the evidence is low, but it doesn't mean that there's no evidence at all. I remember I mentioned about heterogeneity. It depends also the availability. So the number needed to treat in gabapentin is about 6 compared to pregabalin 7. But the issue that I find is gabapentin is more tolerable compared to pregabalin. And the other issue is pregabalin might be more useful in a patient with a lot of tablet burdens. Because if you can remember, the maximum dose for gabapentin to get the maximum effect is 3,600 milligrams. That would be 4 capsules TDS. And I don't think our patients can actually swallow that much of medication. Again, amitriptyline is still very useful. It has the lowest number needed to treat. But again, I think a lot of people would agree with me. A lot of patients cannot tolerate the side effects. So to answer, it depends on the medication availability, and also it depends on patient factors also.
Thanks, Fazina. Sometimes we can have a very long wish list, but reality knocks, right? And all you might have is just amitriptyline, and then you have no choice.
Yeah.
So another question, can morphine be used in renal failure? My center has no fentanyl, and I've noted morphine infusions being used in renal patients, especially at the end of life. Is this acceptable practice?
Okay. So I think in numerous guidelines, it is recommended in renal failure patients. The medication of choice is fentanyl or hydromorphone, which is not available in Malaysia. So it's available in Australia. But I think a lot of guidelines also has mentioned that morphine is not absolutely contraindicated. So it can be used, but it need to be used in caution, meaning that you have to reduce the dose and you have to increase the dosing interval. The concern is with fentanyl, when it's metabolized in the body, the metabolites is inactive, meaning that if it's accumulated, it doesn't cause or it doesn't exert any effect. But for morphine, it is metabolized into morphine 3G and morphine 6G, which is an active metabolite, and it has an effect at the centrally and can cause respiratory depression. But we have used it successfully. So as long as you're cautious about it, you reduce the dose, you increase the interval, and I think it should be safe to use. And I must say that we learned a lot during COVID era, isn't it? So, when, many of you would manage COVID patients, isn't it? And then there are patients, when during the peak season, when they are decided for best supportive care in accordance to their wish or their clinical comorbidity. So it's important to palliate the patient's symptoms in terms of reducing the breathlessness, cough, to make sure that they're comfortable until the end of life. So a lot of guidelines mention morphine infusion, fentanyl infusion, but in the real life, we all know that there are times where there's no infusion available. And if you want to prescribe morphine 4 hourly, a lot of time it's not, I think, doable. Administratively, it's very difficult because there wouldn't be a staff that is inside administering medication all this time. So if your patient has renal failure, using morphine in them is actually an advantage. So that actually negates the use of very frequent dosing with fentanyl. So you can use it as a TDS or QID even with good symptoms control profile afterwards. So the short answer is not absolutely contraindicated. You need to be cautious, reduce the dose, and also increase the dosing interval for the boluses one. If you want to give infusion, just be mindful of the dose. Yeah.
Thank you. Zainal also has a question. And Zainal, I'm going to rephrase your question a bit and make it into a scenario. So I have used morphine for my patient who then became very drowsy in the ward. The family then blames this on morphine and insists on taking it off, resulting in the patient groaning and looking very uncomfortable and restless. So how do you handle this kind of situation when pain management seems to be at the cost of impact consciousness or drowsiness? and you want to have meaningful communication. So how do you talk to the patient and or family about this?
So rephrasing the question, meaning morphine causes impairment in conscious level, but at the same time, the uncontrolled pain is also contributing in, I think, communication and all that. So I guess it's going to be a tricky situation. The first thing first is patient education. So we all know that uncontrolled pain can cause delirium, especially in elderly, but at the same time, a lot of people are worried about a reduction in conscious level after morphine. So what I can share with you, if your patient is frail, use a lower dose and also increase dosing interval, especially in elderly. Education, again, is important. Educate the PAP and the carer that morphine is not the sole cause of reduction in conscious level. A lot of time, patient tolerates it well with low dose. The other thing is you have to rule out other contributing factor. For example, the patient might have sepsis, the patient might have brain metastasis that impair the conscious level, or the patient may have hypercalcemia. So all these things needs to take into consideration. So let's say even if the pain is not controlled, I mean, there wouldn't be any meaningful conversation also, isn't it? So I guess it's finding the balance, education. And let's say if it's really difficult, there's a lot of misconception, and also there's a lot of negative attitudes toward morphine. And I think what you can do is you can change to other opioid. Perhaps you can use fentanyl. That is, I would say, more acceptable to some, especially those with very high concern or misconception. This is, I mean, the main thing is not to devoid your patient's opportunity to get good pain control just because of this morphine phobia. So find other alternatives. Do I answer the questions? Because the question also is quite long.
Yeah, well, we'll see whether people have follow-up questions to that. But yeah, I think we said, right, that we need to have patient-centered care, and our duty is to the patient. And there is a lot of opioid phobia around. We need to try to equip ourselves to be able to answer or try and dispel those myths, right, and misunderstanding about opioids. We'll move on to another question. Can we use... Okay, Zainal said, yes, you have answered his question. Well, okay, thank you, Zainal.
Thank you, Zainal.
Can we use subcutaneous fentanyl as a breakthrough opioid? Because this is being practiced in some centers. If so, what doses do we use? And, can you just explain how you would use subcut fentanyl as a breakthrough opioid?
I think the concept of breakthrough opioid, the definition for breakthrough pain is actually pain that is pain that is perceived on top of either is predictable like bony metastasis, or unpredictable on the top of controlled pain or adequately controlled pain. So that means that the patient is already on the background opioid. So you are adding on the PRN doses for breakthrough pain as and when needed. So the most important thing is to have adequate baseline opioid. And then let's say the additional breakthrough opioid would be short acting. So the short acting ones would be either morphine or fentanyl. So generally, the breakthrough, we use morphine based on what would be your background opioid. If you use morphine, then the background, if you use morphine as a background, then the PRN will be morphine. So it is good practice to not to mix and match, just to avoid confusion. So let's say if you're using a background fentanyl infusion, it's reasonable to use breakthrough fentanyl as and when needed. It's just that if the patient requiring a number of breakthrough, so you need to increase the background by 30 to 50%, or based on the number of breakthrough that the patient has taken. So yeah, that will be my answer. Generally, try not to mix and match if possible. So use one opioid and simplify the treatment. Certainly in terms of data, I think the efficacy of subcut fentanyl and also subcut morphine is comparable. I think in the guideline also as mentioned, and multiple systematic review, no one strong opioid is superior to one another. It's just that oral morphine is the gold standard as a first line in a patient who are still able to take orally just because of the cost, and also it's easily available.
Yeah, thank you, Fazlina. The last question is a slightly loaded question. If I need help with pain management, who can I call? So I suppose there are many people who want to do a lot for their patients, but I think we have to admit that not everyone is comfortable using morphine and fentanyl, oxycodone. Not everyone is comfortable using it. And so, if people need help, even for COVID patients, how do they contact? How do they get help?
I think reach out to clinicians or physicians who are familiar with palliative care. I think there's a number of general clinicians out there who has some basic knowledge in palliative care. And of course, if you have palliative care service in your area or pain specialist, and that will be the person to go. I mean, in community level also, there is increasing interest for palliative care, primary palliative care. So if you are in community, so look out for FMS. So they might be able to help you or connect you with the right service or the right help. Yeah, I would say that.
Yeah, maybe I can also add that in each state, in almost all states in Malaysia, we have hospices, the NGO hospices as well, isn't it? So even if you don't have specialists in your state, you may have expertise in the hospices. You can look at the Malaysia Hospice Council website and look at the list of hospices and see if there's one near you, and you could try to reach out and see whether they could help you, especially if you're discharging the patient home. Otherwise, I guess you could call us in Selayang. You could speak to the on-call specialist. And I think we did get calls at the height of COVID. Yeah, we had calls from East Malaysia, just clinicians who, hats off, I really respect these clinicians. Even though they were struggling with COVID, they still wanted to do more for their patients. And they actually just called up the on-call specialist in Selayang, which was me, and happy to help give some kind of advice, even if it's over the phone. It is 3:58, and I think we have answered all the questions in our list. So Nisha, I guess, Dr. Nisha, I guess I will just ask Fazlina if you have any final words that you have for the participants this afternoon.
No, I would like to say thank you to all of you who are joining us today. So I am actually honored to be here to share with you some of the important points. I know a lot of people are already in holiday mood. So yeah, I mean, for me, tomorrow is weekend. So have a great weekend, everyone. Yeah. So hopefully today, so have a nice day also.
Right. And so I would like to close this afternoon by thanking the College of Physicians and the team behind this webinar series for your kind invitation and working tirelessly behind the scenes to make this happen. Thank you all participants for logging in and interacting with us. And we hope that whatever has been shared will be useful in your daily clinical practice, because after all, palliative care is everyone's business. So have a good week ahead. Merry Christmas and a Happy New Year. Handing the time back to you, Dr. Nisha.
Okay. Thank you so much, Dr. Fazlina and Dr. Cindy, for the excellent session. So I think the QR code will be shared shortly for CPD points. So do join us